Hi, my name's Charlotte. I'm a physiotherapist working at the National Hospital for Neurology and Neurosurgery. I'm going to talk today about respiratory problems in motor neuron disease.
Respiratory muscle weakness affects most people with motor neuron disease. Respiratory failure is the most common cause of death in MND. It's important for you to be aware of how to minimize the effects of this symptom. As MND progresses, the muscles between the ribs and the diaphragm itself weaken, leading to respiratory problems. Some signs of respiratory problems are increased use of muscles in the back of the neck and shoulder, your accessory muscles, to help with breathing, increased respiratory rate, shallow breathing, weak cough, and weak sniff. As breathing difficulty increases, less air is drawn into the lungs. This may lower the amount of oxygen that can be absorbed into the blood. It also becomes difficult for the person to exhale, which can result in a buildup of carbon dioxide. Reduced breathing capacity can lead to daytime sleepiness, breathlessness when lying flat, orthopnea, and even when at rest, dyspnea. The person may experience non-refreshing or disturbed sleep and have morning headaches and fatigue during the day. They may have poor speech volume, decreased appetite, and impaired concentration or memory. They may also feel confused and have nightmares or hallucinations. In addition, a weak cough may mean the person living with MND is unable to clear their throat and their chest, and there may be an increase in chest infections. A baseline respiratory assessment and discussion of future options should be undertaken as soon as possible after diagnosis. Deterioration can happen quickly, so an urgent respiratory referral may be needed. Breathlessness can be distressing, but there are things you can do to make the person more comfortable. Position is important, as sitting in a slumped position restricts lung capacity. Sitting up or slightly reclined whilst well supported may be better than lying down. If excessive saliva or mucus is a problem, seek the advice of the patient's GP, as medication may be appropriate. A speech therapist can also help with saliva control. Try to keep bedroom and living areas ventilated and at a comfortable, steady temperature. The person may experience anxiety with shortness of breath. Breathing in a calm and purposeful way may help until the sensation has passed. A chest management plan can be provided, incorporating chest physiotherapy techniques to support lung expansion and muscle elasticity. Medication can be prescribed to relieve the feeling of breathlessness. Finally, if shortness of breath cannot be managed, the GP or neurologist should be consulted immediately, where other options such as non-invasive ventilation may be discussed. The MND Association Just In Case Kit is a resource designed to hold medication for the relief of anxiety and breathlessness. Having it to hand means people with MND and carers can see that their fears have been addressed. For the GP and district nurse, it provides guidance on symptom management and storage for the prescribed medications. Once the need for a kit has been discussed and agreed with the person with MND and their carer, the GP orders a kit from the MND Connect for the named person with MND. The kit is supplied free of charge. The GP and the district nurse agree on a plan to support the carer to use the kit. The GP prescribes the medication to be supplied. The GP and district nurse give the kit to the person with MND and ensure the carer knows how it can be used. Respiratory muscle weakness leads to the retention of carbon dioxide, hypercapnia. In this situation, the use of oxygen can lead to further respiratory depression. It is important to note that oxygen should only be used for people living with MND under guidance from the person's specialist team. Adequate information and advice are needed so that treatment options can be discussed and decisions made well in advance. This is necessary to avoid possible unplanned or unwanted interventions. If the symptoms related to increasing respiratory muscle weakness impact on quality of life and the therapy is suitable, some people may choose to use non-invasive ventilation. Non-invasive ventilation, or NIV, has been shown to improve quality of life for people living with motor neuron disease, but it may not be suitable for everybody. A trial of NIV can be offered if the person is symptomatic and/or the results of respiratory function tests or blood gases indicate they are likely to benefit from the treatment. A care plan should be prepared in consultation with the person living with MND and their carers and family as appropriate before NIV is started. The plan should cover long-term support offered, that arrangements are in place for device maintenance and details for 24-hour emergency clinical and technical support. This is usually provided by respiratory teams. NIV is delivered via a mask, usually at night initially, and then as required during the day as MND progresses. If you are caring for somebody with MND using NIV, you may find the My NIV resource useful as it explains the treatment very carefully. The potential benefits of non-invasive ventilation include better sleep, improved appetite, the person being more alert during the day. Initially, it may be used selectively and it increases survival. The potential disadvantages of non-invasive ventilation include the mask may cause discomfort or create difficulties when speaking or eating. There is an increased carer burden and there is a risk of aspiration. It becomes less effective as MND progresses, and there is an increasing reliance which may present end-of-life withdrawal difficulties. Very occasionally, a person with MND may be fully ventilated via tracheostomy. This type of ventilation needs very careful organisation and anticipatory planning, as it is often very difficult to support a person who requires this level of ventilation in their own home. Potential benefits of invasive ventilation include prolonged survival, that it remains effective as MND progresses, and there is no mask. Potential disadvantages of invasive ventilation include it requires a surgical procedure, after which it may be more difficult to speak or eat. Complex discharge arrangements after surgery may mean a lengthy stay in hospital. As the disease continues to advance, any prolonged survival is accompanied by progressive disability, e.g., inability to communicate and total dependence on carers. There is an impact on carers and families as the patient will need 24-hour care and special assistance. Dependency is likely to increase, which presents end-of-life withdrawal difficulties. Assisted ventilation, either invasive or non-invasive, is considered to be a treatment. A person retains a legal right to refuse all treatment at any point in their care. Therefore, there may come a time that they choose to discontinue with ventilation. While this is a complex and difficult decision for the person to make, it can be equally challenging and indeed distressing for family members and professionals caring for them. The involvement of local palliative care services can be crucial in supporting the person and the professionals at this time. Detailed guidance on withdrawal of assisted ventilation is available from the Association of Palliative Medicine. Weakening of the chest muscles can lead to an inability to cough effectively. A weak cough can mean that the person with MND is unable to shift phlegm or mucus from their throat or their lungs. This can lead to an increased risk of chest infections. Chest infections can result in A&E admissions. Cough augmentation techniques may help with a weak cough. A referral to a local physiotherapist for an assessment of breathing muscles and to learn breathing and cough augmentation techniques can be helpful. One such technique is breath stacking, in which a person is taught to take 3 breaths in without exhaling, expanding the lungs with more air than exhaling all at once. A step on from this is assisted breath stacking, where you can use a lung volume recruitment bag, or LVR bag, which adds additional air to the air already in the lungs. There is also a helpful technique called manual assisted cough. A physiotherapist will be able to provide instruction on how to do this. Some people with MND find it useful to use a machine called a mechanical insufflator exsufflator. It is sometimes known as a cough assist. It clears secretions by applying a positive pressure to the airway, followed by a negative pressure. This rapid shift in pressure simulates a natural cough and can help to reduce the risk of recurrent respiratory infections. It is also important to note that a patient's bulbar weakness or dysfunction may also impact the use of cough assist, and this should be carefully assessed by a physiotherapist and a speech therapist. A small number of people with MND may experience unexpected coughing or choking episodes brought on by spasm in stiff throat muscles. It's important to note there is no evidence to suggest that people with MND die from these coughing or choking episodes. If coughing or choking occurs, sit the person down, open the window or doors, and get a breeze going past the person, or use a fan to achieve this. You can also help them sit forward slightly so any secretions in the mouth can drain out. Remain calm and reassure that this will pass in a few minutes. Another technique that can be used is a small sniff to try and reopen the airways. Understandably, struggling to cough and choking episodes can be very frightening and cause increased anxiety. Anxiety further affects breathing and makes the airways a little tighter, increasing the work of breathing. The just-in-case kit may be helpful with such episodes. People with MND may experience problems with sleep due to a variety of factors, including discomfort because of immobility, pain due to stiffness of joints or muscles, excessive saliva or dry mouth, breathing problems, or emotional stress and anxiety. Different sleep strategies work for different people. You could advise the following: that they try not to remain in the same position in bed for too long. Satin or silk sheets can help with this, as this may assist them to move in the bed. As breathing may be helped by being slightly more upright, it may be possible to get a profiling bed, which can be adjusted to a variety of positions. Side rails and extra pillows can give added support. A segmented overlay mattress and specialist pillows to distribute body pressure more evenly. They may establish a sleep routine and avoid overexertion, caffeinated drinks, or smoking or heavy meals before bed. Ensure the bedroom is quiet, cool, dark, and comfortable. Changes in sleeping patterns should be reported to the person's healthcare team, who can refer them for a respiratory assessment. If you would like any further information, you can get this from the MNDA website. You can find information on how to get a just-in-case kit. You can also look at the NICE guideline, NG42. You can look on the MyNIV website, and you can also look at the withdrawal of assisted ventilation documentation as discussed earlier. Patient information sheets are also available from the MNDA Association. Here is a list of the available information sheets. 7A looks at swallowing difficulties. 8A looks at support for breathing problems. 8B looks at ventilation in motor neuron disease. 8C discusses withdrawal of ventilation. And 8E looks at air travel and ventilation for people with MND.
I hope you found this webinar useful. If you would like any further information on this topic, then please discuss with your local respiratory service and you'll be able to find more information from them.